Hello and welcome to this webinar which tells you about the findings from the latest annual report for the Learning Disabilities Death or Mortality Review Programme. We call it the LeDeR programme for short. My name is Pauline Heslop. I'm the lead for the LeDeR programme based at the University of Bristol. In this presentation, I'll talk about the main findings of the LeDeR report and the recommendations that we've made based on the findings. Now, this is the fourth annual report of the LeDeR programme, and like other reports, it tells us about the deaths of people with learning disabilities aged 4 years and over. From the 1st of July 2016 to the 31st of December 2019, we were told about 7,145 deaths. Most of these deaths were of adults, as you would expect, and 516 deaths were of children aged 4 to 17 years. In 2019, we were told about 3,060 deaths. That's a smaller number than that estimated by Public Health England, which was of approximately 3,400 deaths of people with learning disabilities in England each year. So in this annual report, we look at all the deaths that have been reported so far, but we pay particular attention to the deaths that we were told about in 2019. We try and see what, if anything, has changed when we look at deaths in 2019 compared to deaths in previous years. Generally, people with learning disabilities were younger than the general population when they died. 37 out of every 100 people with learning disabilities died aged 65 and over. In the general population, 85 out of every 100 people die at that age. In 2019, the average or median age at death for people with learning disabilities was 61 for males and 59 for females. And that's an increase of 1 year for males since 2018. So males with learning disabilities lived on average 1 year longer in 2019 than they did in 2018. The gap in life expectancy between people with learning disabilities aged 4 years and over and the general population of all ages in 2019 was 22 years for males and 27 years for females. This means that males with learning disabilities tended to die 22 years sooner than males in the general population. And females with learning disabilities tended to die 27 years sooner than females in the general population. People from Black, Asian and minority ethnic groups tended to die at younger ages than white British people. 43 in every 100 children who died were from Black, Asian and minority ethnic groups. People with profound and multiple learning disabilities also tended to die at younger ages. 46 in every 100 children have profound and multiple learning disabilities. We looked at the health problems most frequently mentioned in Part 1 of the Medical Certificate of Cause of Death. This is the official record of what a person died from. The most common cause of death is still an infection in the lungs called pneumonia that's caused by germs or viruses. 24 out of every 100 people died from this. The second most common cause is aspiration pneumonia. That's an infection in the lungs caused by food or drink going down the wrong way. And 16 people out of every 100 died from this. So the proportions of people dying from pneumonia and aspiration pneumonia was similar in 2019 to what we reported in 2018. There's not been any real improvement in this. Now you see that Down syndrome is third in this list. We think this is wrong, so we've put it in italics. We can't just leave it out because we have to report what we find, of course. Now we think it's wrong because people don't die from having Down syndrome. It's not an illness. but we can see that doctors still write Down syndrome as a cause of death in the official records of why a person dies. And they most frequently do this when a person has died from Alzheimer's disease, which is a form of dementia. Having Down syndrome increases the risk of developing Alzheimer's disease. So doctors sometimes write both Down syndrome and Alzheimer's disease on the official record of the person's death. The other most common causes of death were dementia, sepsis, and epilepsy. We looked at the list of illnesses that's used by the Office for National Statistics when it reports on avoidable causes of death. Note that these are possible deaths caused by particular illnesses where it's thought that a person should not die from that illness. So they're called medical avoidable causes of death. We're not talking about deaths that could have been avoided if someone had done something differently. So 44 out of every 100 people with learning disabilities had a medical cause of death considered to be avoidable. But this is the case for only 22 in every 100 people in the general population. Now we know that we get more illnesses as we get older, and we've already seen that people with learning disabilities don't tend to live as long as people in the general population. So we need to take that into account. So let me talk you through this slide. The first two rows show the rate of avoidable causes of death for people with learning disabilities, and that's the dark blue bar, and people in the general population, that's the patterned row. And it shows that when we take account of the different ages of the groups, people with learning disabilities still died from avoidable causes of death far more frequently than people in the general population. 520 per 100,000 people with learning disabilities died from these causes, compared to 227 per 100,000 people in the general population. Now, there are two groups of avoidable causes of death. First are causes of death that are treatable, such as infections. Generally, people shouldn't die from illnesses that we can treat. So the third and fourth bars in this diagram show that people with learning disabilities, and that's the dark blue bar, died more frequently from illnesses that we can treat than people in the general population, and that's the patterned bar. The rate was 403 deaths per 100,000 for people with learning disabilities, compared to 83 per 100,000 in the general population. So the second group of avoidable medical causes of death are causes of death that are preventable. So these are illnesses that we could prevent from occurring in the first place. An example is lung cancer caused by smoking cigarettes. Now here there was less of a difference between people with learning disabilities, again the blue bar, and people in the general population. And that's the pattern bar at the bottom of the diagram. But it is still a really important difference. So overall, we know that people with learning disabilities were more likely to die from illnesses that could be avoided, and particularly illnesses that could be treated, than people in the general population. We looked at what reviewers said about the quality of care given to people who died. And this slide compares the findings from 2018 in the dark blue bar and 2019 in the pattern bar. So the two bars on the left-hand side of this figure show that more reviewers in 2019 thought that the person's care was as it should have been, which is great. So there's actually an increase from 48% in 2018 to 56% in 2019. But that still means that only just over half of the people whose deaths were reviewed were thought to have received care that met or was better than good practice, whereas really all people should expect this. Now, where there were big problems in the person's care, there was little improvement between 2018 and 2019. You can see that the bars on the right-hand side of the graph are about the same size. So what were the areas of best practice most frequently mentioned? These were about person-centred care, so putting the needs of the person at the centre of everything. About multi-agency working, so different people from different services all working well together. It was best practice when there was involvement of advocacy services. And it was best practice when there was the use of reasonable adjustments, so changing the way things are usually done to take account of the needs of the person and their family. The main areas in which there were problems with a person's care were with delays in finding out what was wrong with a person and treating their illness, different services not working well together and sharing important information, people receiving care that was not of a good standard, the Mental Capacity Act not being followed as it should be, people not being referred to specialist services, including learning disability services, as quickly as they should, and people with learning disabilities not having their death reported to a coroner as often as other people. We looked at some things in more detail, how families are involved in making decisions, certain causes of death, and deaths of people of certain ages. I'll quickly summarise these for you. When we looked at family involvement in decision making, we found that most reviews referred to some family involvement in decision making, which is great. But there were some examples of best interest processes as required by the Mental Capacity Act not being followed. And these were largely when professionals had found it difficult or they'd faced challenges. And they were mostly around problems in contacting a family member, problems with knowing which family members to contact, disagreements between family members, and making sure that families understood the decisions to be made. The families we shared these recommendations with, the families we shared these findings with, recommended a need to improve people's understanding of the Mental Capacity Act and to make sure that it's followed. So we looked in more detail at deaths from certain causes of death. Let's start with pneumonia. Pneumonia and aspiration pneumonia were the most common causes of death. And they're also potentially preventable and treatable conditions. And we've already seen that about 40 in every 100 deaths were from bacterial pneumonia caused by germs or pneumonia caused by food or drink going down the wrong way. So we looked at what recommendations reviewers made in relation to deaths from pneumonia. Their recommendations included better training for family and paid carers about risk factors for pneumonia and how to reduce these. The need for a national clinical care pathway for pneumonia. A clinical care pathway is an agreed way of managing a health condition that involves different professionals. It's so that everyone knows what to do and how to do it. Paying attention to postural support, helping people to have good posture so that they can breathe well. Making sure that people with learning disabilities have flu and pneumococcal vaccinations. Making sure that people have healthy mouths and teeth, and that people see a dentist regularly, so their mouths don't have infection that can travel down to their lungs. and a review of the effects of antipsychotic medications on people at risk of chest infections or aspiration. Antipsychotic medication is usually given to someone with mental health problems, but it's sometimes given when a person has behaviour that's difficult for those supporting them. We also looked at deaths from sepsis. Sepsis is an infection that affects the whole body, and it needs to be treated very quickly. The proportion of deaths from sepsis was similar in 2019 as it was in 2018, at 7 in every 100 deaths. Recommendations that the reviewers made in relation to sepsis included the provision of training for families and paid carers about preventing infection and recognising early signs of sepsis. The provision of training for health professionals about the provision of reasonable adjustments. And the need to adapt the national early warning tools, for example, News 2 or Restore 2, to meet the needs of people with learning disabilities. And these tools are used to help notice early signs that a person's health is getting worse. We also looked in more detail at deaths from epilepsy. 6 out of every 100 adults and 16 out of every 100 children with learning disabilities died from epilepsy in 2019. That was a greater proportion of children than in 2018. Recommendations made by reviewers included the need for training about epilepsy for those supporting people with learning disabilities. GPs and neurology services to work better together. There should be regular reviews of a person's medication. That local areas should check that services are following National Institute for Health and Care Excellence, that's NICE, guidelines for epilepsy. And that there should be an assessment of the use of seizure alert devices. These are things such as bed mattresses or wrist alarms that make a noise when a person appears to be having a seizure. We also looked at some health problems that could be avoided or treated at home. People shouldn't usually need to go into hospital because of these conditions or to die from them. The conditions we looked at were blood clots in the body. We call that pulmonary embolus or deep vein thrombosis. Secondly, diabetes, which is an illness where your body gets too much sugar from the food you eat, which can damage your body. Thirdly, asthma, which is when a person's breathing doesn't work as well as it should. It's often treated with an asthma inhaler. And fourthly, flu, a virus that often spreads in the winter. And we found that over 300 people died from these conditions. So we definitely need to improve the prevention, recognition and treatment of each of these conditions. Now, I said that we also looked at deaths of people in particular age groups. Let's start with deaths of children. 7 in every 100 deaths notified to LeDeR were of children aged 4 to 17 years. That was 246 deaths in 2019. But in the general population, fewer than 1 in every 100 children die between the ages of 5 and 19 years. The deaths of children are reviewed by the Child Death Review Programme, and that sends the LeDeR programme the reports of the deaths of children with learning disabilities. Now, we've already mentioned that of those who died in childhood, 43 in every 100 were from Black, Asian, minority ethnic groups, and 46 in every 100 had profound and multiple learning disabilities. Recommendations specific to children were the need for a key worker to make sure that everyone was working well together and that their care was coordinated. Good care plans that thought about the future as well as the present. Better planning and coordination when a person was leaving hospital. and consistent support for and communication with families. We also looked at deaths of young people aged 18 to 24, and we found that they died from different sorts of illnesses than other young people. So they are more likely to die from epilepsy or pneumonia. And we also found that there were still problems in the move from children's services to adult services for some of them, as we highlighted in our last year's annual report. So finally, we looked at deaths of people aged 75 years and older. 15 out of every 100 of the deaths notified to LeDeR were of people aged 75 years and over. But in the general population, 68 out of every 100 people die aged 75 years and older. People with learning disabilities aged 75 years and older were less likely to be from Black, Asian and minority ethnic groups compared to white British ethnicity. And they were more likely to have mild or moderate learning disabilities rather than severe or profound and multiple learning disabilities. The recommendations that reviewers made that were specific to people aged 75 and over included paying greater attention to forward planning as people get older, recognising that a person's experiences when they are young, such as living in a long-stay institution or hospital, can impact on their life in later years, better training about the needs of older people, and services to work better together to provide joint care planning and information sharing that takes account of the needs of the person. We've made 10 new recommendations this year, but we also need to make sure that the recommendations we made in previous years are followed. Before I talk about those, let's just think about what we need to do more of. We know that good quality support includes services working together to meet the needs of the person and their family. We call that good multidisciplinary working that has the person and their family at its centre. The second thing we need to do more of is for there to be a named person taking the lead to make sure that services work well together. And thirdly, we need to make sure we're planning for the future as well as thinking about the present. It works well when services take a proactive approach to meeting health and care needs. So we need to do more of all of this and to ensure that it's more firmly embedded in systems and processes. So the first 3 recommendations we've made are about making sure that people with learning disabilities are not treated in an unfair and unequal way. We must keep checking up on the deaths of people from Black, Asian and minority ethnic groups. They died younger than other people with learning disabilities. We need to ensure a continued focus on their death, both within the LeDeR programme, but also in other work. The second recommendation is that the Chief Coroner should make sure that deaths of people with learning disabilities are being reported to a coroner whenever they should. We suggest that the government needs to work with the Chief Coroner to identify the proportion of deaths of people with learning disabilities referred to a coroner in England and Wales. And our third recommendation is that inspections of services by the Care Quality Commission must check that people are following the Mental Capacity Act. The next 3 recommendations are about the quality of care given to people with learning disabilities. The fourth recommendation is that the government should look at the best way to make sure that people with learning disabilities receive the support they need with different services working together. Specifically, we suggest that they should look at the recommendations from the report called Best Practice in Care Coordination for People with a Learning Disability and Long-Term Conditions, and that they should take action based on this report. The fifth recommendation is for the checklist called News 2 to be adapted for people with learning disabilities. News 2 is used to help notice early signs that a person's health is getting worse. And the 6th recommendation is to test out having specialist doctors for people with learning disabilities. We suggest that the Department of Health and Social Care and the Royal College of Physicians should consider developing, piloting and introducing specialist doctors for people with learning disabilities and to make learning disabilities a speciality. Our last 4 recommendations are for specific areas of focus to improve the lives of people with learning disabilities. Recommendation 7 is for the National Institute for Health and Care Excellence, or NICE, to consider the need for new guidelines for the prevention, diagnosis and treatment of aspiration pneumonia that includes adults and children with learning disabilities. Recommendation 8 is that while the NICE guidance is being developed, Right Care should provide a toolkit to help to improve outcomes for adults and children at risk of aspiration pneumonia. Our 9th recommendation is that we need to improve the safety of people with epilepsy. We suggest that we could do this through the better use of seizure checklists and risk assessments, the provision of training for people with epilepsy and those who support them, each person having an up-to-date epilepsy care plan, having as a minimum an annual review of one's epilepsy, people having easy access to an epilepsy specialist nurse, and safety protocols being followed and checked up on in CQC inspections. Our final recommendation is that we need to find out more about people going into hospital for health problems to do with constipation. We recommend that this is through a national clinical audit. 23 in every 100 completed reviews identified constipation as a long-term health condition, and 33 in every 100 reported that the person was usually prescribed laxatives. The information available from completed reviews about deaths related to constipation will take some time to analyse fully, and more detailed information is required about those deaths to more accurately identify and assess the contribution of long-term chronic constipation to deaths. Finally, I want to leave you with a quote from a father of somebody who died. This father said, "If your programme prevents the loss of one more vulnerable adult's life or ensures that they are treated with empathy and dignity, you may use any information. It cannot bring back my son, but it can help others." As I said, this is a quote from the father of a person who died. And I think we need to ask ourselves why this family feels that empathy and dignity were in short supply for their relative. We have so much more to do to make sure that people with learning disabilities receive the same good standard of care that anyone else would expect to receive. The actions taken so far have been clearly insufficient. We must do better. In finishing, we suggest that what we now need is urgent policy and practice level changes in response to the issues raised in this report and in previous reports. Thank you.